The patient is 83-year-old female with duodenal tumor at the major papilla. EUS and MRCP show no signs of invasion to the bile duct and pancreatic duct. A papillectomy will be performed by Dr. Robert Hawes.
So welcome to OR 15. So I am in very, very good shape here because I have a team of experts behind me who will teach me how to do this procedure. And I have Anna and Bergen, who are nurses with Stefan Siewald. So communication is very, very important in the endoscopy suite. So it is a big help for me to have Anna and Bergen with me. And then Horst and Guido Takao will all help me to perform this case. So I think the first sort of part of approaching an ampullary tumor is to understand its extent. And the thing that sort of points out to me or is most noticeable to me is that this is almost pedunculated. It's got an intramural segment here that I'm exposing with this catheter. And it will be very important for me to land the snare on the normal part of mucosa here, sort of where the tip of the catheter is. It's also very important that you do the maneuvers necessary to make sure you can get below it, because the technique that we will apply is to open the snare on the upper part, up in here. Once you embed the snare, then I will ask Anna to slowly open it as I push the scope in and go right on my right, left, and then I will let the elevator down to seed the snare in the normal mucosa down here. Now, I think techniques vary widely. We do have both an endoscopic ultrasound as well as an MRI, and so I know that this is normal pancreatic anatomy. And so the need to do an injection in this particular circumstance is not so necessary. If I don't have an MRCP, so that there could be a possibility of devesum, then I generally like to do a pancreatogram. But I think in this case, Horst and Guido, if you agree, it's probably not necessary.
No, I would directly resect that.
And I know Horst, lately when I watch him, is very conscious about injecting contrast into the pancreas. And for me to inject now, it would just be an extra injection that's probably not necessary. So I think we will proceed directly to ampulectomy if everybody is okay. Yes. So Guido mentions there's a small diverticulum here. I don't think that really plays a role in the resection. Ampulectomy when the papilla is in the middle of a diverticulum can be quite difficult.
And is there any need for injection? Because this is a frequently asked question.
Yes. So very, very good. So there is no indication for injection if the polyp is not spreading laterally. So this one, always there's a little what I call a beard. There's a little bit of beard coming down here now. If I wanted to, Horst, I could inject this area here, but I don't think it's necessary.
No.
And the problem with injecting is if I inject here, it will simply elevate the surrounding mucosa and just it'll bury the papilla into the surrounding cushion. So I think it is actually a negative thing to inject. So I'll take out the 1.5 centimeter snare. Opinions vary as to what kind of snare to use. Some people like a monofilament snare, a very stiff one. Some people like a very, very flexible snare. I prefer sort of a braided snare.
This is Snare Master, huh, from Olympus.
Yeah, from Olympus, yeah.
Yeah.
So I prefer a braided snare that's sort of medium stiff. If it's too stiff, then I have a difficult time putting it below the lesion. If it's a too soft a snare, then I think it may slip on the upper part.
And you chose a 15 millimeter in diameter, or
I chose a 15. I think that will be okay. Do you agree, Guido? So begin to open the snare. So you want to stop. So you want to open a little bit. And again, getting the snare purchased or embedded in the top, I think, is one of the most critical points. I want to get normal mucosa. I don't want to cut through the polyp. And then you've got to get it to spin. And then we will open it up further as we go down. So the embedding, this part of the procedure, to me is sort of critical. Okay, so open more, Anna, if you can, and we'll see if this will rotate. So I'm pulling back on the scope now, pulling back on the scope. I'm going to, again, pull back on the scope to get underneath this. I will use my left and right directions to get on the side of the polyp. And now my only concern now is that this has slipped. And so that I'm not fully on top of it. So I want you to close just a little bit, Anna, if I can. So close a little bit. See how that had slipped down. And so I really want to get up on the top of that. Okay. Okay, Anna. Open just a little bit, not too much. Okay, stop. Okay. So now I will pull the scope back. I will advance the snare. I lock my up down, and now I'll ask Anna to close. I've let my elevator down so that she can feel the closure. And I advance the papilletome, or the snare, I should say, to the bottom. Now, it's very important if the cameraman can look at Anna's hands, because she's closed very tightly. It's really important that you close tightly around this, the ampulla. It's not a very gentle closure and then a slow cut through. It's a very tight closure on the snare. So this is critically important. I'm using EndoCut Q, which is my preferred setting for this. And you will see I generally do a little bit of shaking. The shaking is not necessary. It's more of a sort of a nervous tick. I'll make sure that this is sort of mobile, and I think we're ready to go.
So it's on 214,
Yeah.
cutting duration 1 and cutting interval 4, energy level 2.
Yeah. So we're padded. Always check to make sure we're padded. Anna is hot, what I call hot, so that is all ready to go. And then finally, you need to work with your assistant to understand what the strategy is for the polyp once we remove it. And what we have decided upon is that we will try to grab it with a snare after it's resected. We don't want it to fall all the way down in the duodenum if we can help it. So are you ready? Okay, so here we go. I lower my elevator so she gently closes, and now we need to at least deposit this in the stomach. Okay, and so for time purposes, I oftentimes will pull this out completely, but open up, and we will retrieve this at the end of the procedure. Okay, so now this is a fairly small lesion, and the duct is not very dilated. And so I would like to show the audience, this is just my preferred accessory for cannulation that I would like to show you. So this is a catheter from Boston Scientific. It's called the 543. So I believe in small ducts using small catheters and small guide wires. And then if Anna, if you can advance the guide wire. This is another Boston Scientific device called the NovaGold wire. It's an 0.18-inch wire, and it's a nitinol core, but it's got a coil end on it. And you can see here that the end is exceedingly flexible. And a maneuver that I very, very much like is if I can manipulate the wire in the pancreatic duct to make a J shape, then that has great advantages because it avoids side branches. So this is the catheter that I prefer to use. It's a little bit foreign to Anna, but it is what I like. So now we need to look at the area. I think first it's difficult to tell if the resection is complete because of the cautery. The main issue now is to localize the muscle fibers of the ampulla. And I would propose to you likely there is an opening here, and potentially there is an opening up here. You want to probe very gently here. It's sort of an exposed area, so I want to probe very gently, not in an aggressive way at all. So take your time at this point. And again, another option would be to use a soft tip wire, maybe the Terumo wire or a soft tip wire, but I prefer this one. So again, gently probe the area. I think because this was sort of a long intramural segment, I suspect that the openings are not going to be very big. So there's one of them. I don't know which that is. I've probed very gently now, so I'm comfortable that I've not perforated or anything like that. So if we can have the fluoroscopy, and Anna, if you can inject just a little bit, please. Yeah. Okay, so that's the bile duct, I think. Mm-hmm. Okay. So that's the bile duct. Now I will pose a question to Guido and to Hawes. Do you ever do a biliary sphincterotomy?
Only if there is a suspicion of intraductal extension of the adenoma. If EUS shows that there is some extension into the bile duct, then we would proceed to biliary sphincterotomy. Otherwise, it's not necessary.
Yeah, I think there's very few cases of cholangitis reported. If you really need to inspect the the distal bile duct, the intraduodenal segment of the distal bile duct, then you're right, you have to do a sphincterotomy. The only thing that I've found occasionally is on an ampulectomy like this, when it heals and closes off. And then I don't see things as well for the follow-up. Now, either the pancreatic orifice is up here, or the pancreatic orifice, I think, is down here. And I favor this, maybe you can't feel it like I can, but there's a little bit of a firmness to this area here. The advantage of a soft tip wire right now is that it would be a good leading edge to get into something that's very, very small. The downside of the wire that I have is that it gets caught pretty easily. Well, I am going to ask Anna to just advance the wire a little bit, and let me see if I can use that.
So Rob is a real expert and does it very, very carefully. If you do not succeed after some time, I think it's not justified. I would not recommend to try too extensively to cannulate the pancreas, because the evidence of decreasing the risk of pancreatitis is not very strong. It's based on a very small randomized controlled trial, including only 19 patients. So I'm not convinced that it's per se necessary to place a pancreatic stent.
Do you agree with that, Guido?
Yes, I agree. I was thinking that one of the advantages of having a pancreatography before resection is that you can put some drops of methylene blue in the contrast, what we usually do, and it facilitates a lot the after resection the recognition of the pancreatic orifice, at least the position of the pancreatic orifice.
So I've tried that several times, Guido, and it hasn't worked for me very much.
No?
But is it something that you will routinely do?
We routinely do, yes.
Pull back on the wire. I'll pull back on the wire, yeah.
Do you inject secretin? No, it's not available in the US for secretin stimulation.
The secretin is available.
Okay.
So one option here is to inject some secretin to sort of locate the opening itself. It's possible that this is not the opening, and it's possible that the opening is further up here. It will just take some time, I think, to... Floro?
Rod,
Oh, yes.
can I ask just one thing?
Check.
Initial contrast injection may have shown a little bit of distal pancreas
Pancreas,
as well. So you may want to do that.
So it's always good to have a Norio in the background because he's very, very astute. So we talked about this. There can be... Okay. So, Floro, and can you advance the wire now? Go ahead and advance that. Ah. Now maybe.
Yep.
Oh.
Aha.
Okay. So go ahead, Anna. Slowly. Oh, stop. Okay. So let's inject a little bit of contrast. I know that Horst, when I've watched you, you don't like to inject any contrast. I, for one, like to see the conformation of the duct. There it is. Okay. That's enough. It'll go on up. There we go. Okay. Perfect. Okay. So that's far enough in. We only have available 5 French stents. For me personally, it would be a little bit different. Floro? Okay. For me, I would use either a 4 or 3 French stent, and I would leave it long in the duct with no flap to retain it. So it migrates out in about 3 weeks' time. But we don't have that available, so we'll use a longer 5 French stent. So if you have a 7 centimeter long. So I'm going to come back now. We're going to do a exchange. So this requires Anna and I to work very carefully together. Okay, slowly. Okay. Now, this wire off on the floor. This wire is gripped very well by the Olympus elevator. And I think it's a pretty stiff wire and one that we can easily work over. So I've chosen a 5 French stent. It does not have a pancreatic flap on it. so it will migrate out spontaneously. But because it's about 7 centimeters long, it will take a little while for it to migrate out. The duct, I think, is plenty big enough to accommodate a 5 French stent, and the conformation of the duct is very smooth. If this was a sigmoid type duct, so it goes like this, then you can only use a short stent in that circumstance. You don't want to put a stiff stent around many curves of an otherwise normal pancreatic duct. So this is the stent here, 5 French, 7 centimeters long, no flap on the pancreatic side, but flaps on the duodenal side.
And you prefer a straight tip instead of a pigtail at the duodenal side?
Yes, I do. If there's no flap, then a pigtail is fine, no problem. But I am very careful with a one that has a flap and a pigtail, because if it does migrate in, it will be very, very difficult to remove. But I prefer the straight. You prefer the curve?
Not necessarily, no.
Okay, so I can feel now at the elevator the stent is there, so I'll ask for fluoro. Anna will watch the fluoro. I will watch the stent. She will pull on the wire to make sure that the wire does not go into the patient. And here we go. And there's the flap. And now I will go ahead and pull the wire. Yep. Pop it. So normally, bleeding will occur in this lower lip. Not the sphincter fibers themselves up where the stent is, but bleeding will occur on the lower lip. This, other than that little area where I was poking on, maybe that's something significant, but I don't see anything to treat or anything. So I think that I think we are done.
Okay, thank
Excellent.
you.
So,
Thank you for your wonderful
questions
lecture.
or anything?
We have to move on to the next case.
Okay.
We're going